Okay, so I am going to go through this respiratory quickly and try and pull out just really what you need to know. And then I'm going to try and go through, switch right into the endocrine system real quick so we can just kind of review. I forgot my book, y'all. So I have to strictly go by the slides, okay? And so we're just going to pull out the basic things what you need to know, okay? The respiratory system, don't make it more complicated, okay? The way you need to consider it is as a pathway. That's it, directions, or a pathway to your goal, I guess is how I would look at it. So when you take a breath in, it's almost like taking cars in. The cars just follow a path. That's it. They go here, 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 and they either go left or right, and they get to their destination, which is down here. And each part just does a different thing to guide that car down to its destination. So the same as I said, it's like air. You just take in air, and all of this just guides the air where it needs to go. It decides to go left or right, and its destination is down here. It gets I don't want y'all to make this complicated because it does get a bit more complicated when it comes to the O2 and the CO2. A lot of this, again, is just first memorizing the pathway that it goes from here to here to here to here. And then kind of understanding what each part does, which again, majority of these parts just kind of moisten the air, filter the air that we take in, moisten it, and then just guide it to its destination. So the respiratory system, and I'll send this to y'all, this other one to y'all as well. So you see it kind of has the same pictures, but the way I like to break it down is you have an upper respiratory tract and you have a lower respiratory tract. Yes, you need to know what parts belong to the upper and what parts belong to the lower. But I like to number them. So, like, the first place is your nasal cavity, that's 1. Then the air hits your pharynx, which is 2. Then it hits your trachea, which is 3. Then it hits your bronchi, which is 4. Then it hits the bronchioles, which is 5. I'm missing one. I'm sorry, let me do it one more time. So it hits the nasal cavity, 1. The pharynx, 2. There we go. The larynx is what I'm missing. I apologize, y'all. I missed it right there. Okay, so again, the air hits the nasal cavity, 1. To the pharynx, 2. To the larynx, 3. To the trachea, 4. To the bronchi, 5. To the bronchiole, 6. To the alveoli is 7. That is the pathway of air. Okay, your upper respiratory tract, you have your nasal cavity, and then you have your pharynx. Your pharynx breaks down into 3 different parts, like subparts. Okay, you got nasal pharynx, oral pharynx, laryngopharynx. Ooh. But these 3 parts make up your pharynx, and you can see it's just the different areas. Then it hits your larynx, which is kind of where your throat is. If you notice, it's kind of where your Adam's apple is a little bit. And then you have your trachea. And you can see it's going to get a little bit smaller here. It breaks into the bronchi, into the bronchioles, which gets smaller. And then they hit the alveoli. And this is where your alveoli sacs. This is where gas exchange happens, O2 and CO2. I'm sorry, I was doing the upper respiratory tract. Includes your nasal cavity, your pharynx, and your larynx. Okay. And then your lower respiratory tract is your trachea, your bronchi, your bronchioles, and your alveoli. So know those differences. Again, right here, your upper is your nose, pharynx, larynx. Your lower is your trachea, bronchiole, and lungs. Bronchiole tree, that's going to include your alveoli. Okay, your upper respiratory tract, I'm going to say this real quick, consists of structures, and we said it was the nasal cavity, the pharynx, and the larynx. These 3 things together, majority your nasal cavity, right? We have cilia in our nose. We remember when we do our head to toe, we're looking for cilia, right? The cilia is going to filter the air and what we take in. Okay, the rest of the parts is going to moisten our nose, our nasal cavity, kind of going into into here is going to filter the air, is going to moisten the air, is going to warm the air. So our upper respiratory tract does that before the air hits our lungs, because everything in our body needs to be moist. Nothing is really dry except for our skin, and even our skin is not truly dry. But everything needs to be moist, including air. So our nose, the cilia in our nose, and then the rest of our upper respiratory tract, again, is going to filter, is going to moisten, is going to humidify the air before it hits our lower respiratory tract. Okay, again, your nasopharynx, your oropharynx, your laryngopharynx, those three together make up the pharynx. I don't know if you can see that. Okay. Kind of shows you a side view, your nasal cavity. Y'all, when we do that PCR COVID test and it feels like they're taking brains, or when we do NG tubes, in your nasal cavity, you have a little hole on the side. If you were to look inside your nose, on the very, before you can go too deep in there, at the very start of it, you have a little hole inside. And that's where that PCR COVID test actually goes. And that's where the NG tube actually goes, this way and then down this way to the esophagus. But okay, so your nasal cavity, again, the air comes in here. The cilia is going to filter it. All of this is going to moisten it and humidify it. And then it's going to come down into the trach. Oops, down into the trach. Okay. You've got your larynx from the front view. You got your epiglottis. Epi means above, so it's going to be above the glottis. You got the hyoid bone. Remember, we learned that was the only bone that didn't connect to another bone. The only single bone that sits alone in our body. That's not really a joint. Okay, you have thyroid cartilage. Then you have cricoid cartilage. You have these C rings. We call them C rings, but the cricoid cartilage, they form structure around the trach, because without those, the trach would just flop over. It would be like limp. Okay, so these cartilage kind of help stabilize your trach. Which is a function of the nasopharynx? Filter dust, warm and moisten inspired air, provide openings for eustachian tube, contain olfactory receptors for sense of smell. C, filter dust, warm and moisten inspired air, and contain olfactory receptors. Oh, I'm sorry, are all functions of the nasal cavity. And we said this was the nasopharynx. Oh, what was C, y'all? Provide openings for eustachian tubes. Okay. Lower respiratory tract is going to include the trachea, the bronchi, and the lungs, and this is going to include the alveoli. This serves to distribute air into the interior part of the lungs. Perfect, right here. So again, remember, everything is a guide. The nose is going to guide the air to the pharynx, and then the pharynx is going to guide it to the larynx, and the larynx is going to guide it into the trachea, and the trachea is going to guide it into the left and right lungs. If you see these lines, these fissures right here, these are the lobes. So these are 2 lobes, and you see it makes room for the heart, and this is 3 lobes. Shoot. This is 3 lobes because we have more room over here. When most people choke on something, it is most likely, not always, but most likely, that the object is stuck more towards the right, because the right is a bit wider and it has 3 lobes. So fun fact for y'all. Okay, your carina is the very end before it breaks off into the left and right bronchi. Okay, a lot of times with adults, when you're suctioning, like when you're suctioning in trach, they'll tell you go until you hit resistance, and resistance is going to be this carina right here. That's going to, when you stimulate that, it's going to cause them to cough, like a cough reflex. If I'm correct, I don't think they're doing that anymore till you meet resistance. I think it's just until you can kind of hear some sort of suction in, and then if you need to go deeper, you do. But you'll hear a lot of the older nurses talk about that. Just go till you meet resistance, and they mean just go until you hit that carina. Again, it's going to stimulate them to cough and hopefully cough up all the stuff within reach for the suction catheter to suction it out. Okay, so you got your trachea, you've got your carina, you've got your bronchi, which are it just kind of breaks down into smaller pieces if y'all see. The trachea is pretty thick, pretty wide, and then these bronchi are a little bit smaller, and then the bronchioles and the bronchial trees are smaller. And that's why they go primary, secondary, tertiary. Woo. Okay, primary bronchi, secondary bronchi, and then tertiary bronchi, and then you got your bronchioles, which are even smaller, and at the end of the bronchioles is where we have our alveoli. A layer of protective mucus coats the lining of the bronchial tree. This helps purify air. Millions of hair-like cilia line the mucosa to help move mucus towards the pharynx. So that's what this is over here, respiratory mucosa, mucous membrane that lines the air distribution tubes in the respiratory tree. Mucus produced each day forms a mucus blanket over much of the respiratory mucosa. Mucus serves as an air purification mechanism by trapping inspired irritants such as dust and pollen. Cilia or mucosa cells beat in only one direction, moving mucus upward towards the pharynx for removal. So, remember, mucous membranes, they line things. They're like a lining, like an extra layer on the inside of that organ, right? So they line things, and these goblet cells right here, this is what produces mucus. Okay, I need you to know that your goblet cells produce mucus, and the mucus that's produced is real thick, real sticky. So anything that we inhale that's not supposed to be in our body, that mucus, the hope is that it's going to stick in that thick mucus. And then the cilia is going to propel any of that mucus or that stuff that's not supposed to be, or pollutant, out. It's going to grab it and it's going to beat it in one direction, and it's going to so it's going to hopefully push up towards the trachea so we can cough it up and be able to cough it out of our mouth, or if they have a trach, be able to cough it out the trach, so we can suction it up. Again, structure, so we have a left and right nostrils, and in the middle we have a septum, which is your nasal septum. If you remember, when we're doing head to toes and we're filling on the septum, we're looking for a nasal deviation, septum deviation. That septum in the middle right there should be midline, should not be crooked or look like it's swollen or have been broken before. That septum separates the nasal cavities into left or right. You have a mucous membrane that lines the nose. At times you can get polyps, which are non-cancerous growths, and they form from the mucosa located in your nose. You've got sinuses, your frontal, maxillary, sphenoid, and ethmoidal sinuses. They drain into your nose. Okay, so your sinuses, remember when we're doing head to toe, right? We're filling on the sinuses with our thumbs because we're looking for any swelling. We're feeling for any swelling. We're palpating for any swelling, any tenderness, and then we're assessing our patient's face for any signs of pain, for any signs of withdrawal. But these are our sinuses. A lot of times when we get sinuses and we feel stuffy, remember these sinuses are made, the lining is epithelial tissue. So if anything gets in there that's irritated, that epithelial tissue is going to swell up and inflame. And then we're used to having it empty. We breathe, it's no big deal. But when it's inflamed, the air can't get through. So we have our frontal, our ethmoid air cells, and then we have our maxillary sinuses right there. Okay, function of the nose, as I said, is to warm and moisten the air that we breathe in. It also contains our sense organs of smell. If you all remember that from the senses, if not, please go back and read it. Structure of our pharynx. So remember, it goes from our nose to our pharynx to our larynx. So our pharynx is divided into three subdivisions: nasopharynx, oropharynx, and laryngopharynx. The two nasal cavities, mouth, esophagus, larynx, and auditory tubes, all have openings into the pharynx. So the pharynx is like my throat. Excuse me, guys. So my nasal cavities, right? When we have sinuses, we feel it draining. That's coming from our nasal cavities. Our mouth, all that saliva that's coming out in the back, it all empties the stuff from the nasal cavities, the mouth, our esophagus, our larynx, and auditory tubes all have openings into the pharynx. So they all have some little holes that open into the throat. Okay, you have pharyngeal tonsils and openings of auditory tubes. They open into your nasal pharynx. Other tonsils are found in your oral pharynx, and your mucous membrane lines your pharynx. So when it comes to, I'm sorry, guys. And I may have mentioned this when we were talking about ears. I may not have. But our eustachian tubes or our auditory tubes, they lead from our ears into our throat. Okay. And that's why, like, when babies or younger people, they get when they get ear infections, they'll get strep throat, or strep throat infection will cause ear infection, because it's such a short tube in between each that if I have strep throat, that bacteria is trying to find somewhere else to go, and it's going to climb up the build up the eustachian tube into my ear and cause an infection there. It's going to set up camp there. Or if I have an ear infection, that bacteria is looking to spread, to set up camp in the other area. So it's going to go down that eustachian tube and into my throat and feel like it can set up camp there. Okay, so that was the structure of my pharynx, right? You got the nasopharynx, the laryngopharynx, and the nasopharynx, the oropharynx, the laryngopharynx. And all three of those make up the pharynx, okay? Now, the function of it is a passageway for food and liquids. So, where's my, look, y'all, that's the uvula right there, right? And you see this flips up, okay? The uvula, that's why when we say ah, we need to make sure that reflex is it's working, sorry. Where's my so there's my oral pharynx, my nasal pharynx. There we go. So you see the auditory tubes, they open into the throat, the nasal pharynx, and then the oral pharynx and my laryngopharynx. So when we eat, we take food into our mouth, right? And when we take it here, where's my esophagus? My esophagus is right here. So my esophagus is right here. My esophagus takes food to my stomach. My trachea is right in front. It's right here. What that does is take the air into my lungs. So your body has something that will cover each hole depending on what we're trying to do. Hence why you cannot eat and take a breath at the same time. Hence why people choke, because they're trying to eat. They're trying to swallow and take a breath at the same time. That epiglottis, which covers that hole, the trach, to allow food to go down into the esophagus, it gets confused when we're trying to take a breath and swallow at the same time, and then we choke and it goes down our trachea. Okay, I'm sorry, y'all, I got off topic. So the pharynx, right? When we eat, the food and the drink is going to go through our pharynx, but then it's going to go down our esophagus to our stomach. The pharynx is also for air distribution, passageway for air. As I said, it is just a passageway to allow air down. Your tonsils are masses of lymphoid tissue embedded in your pharynx to provide immune protection. Our tonsils, when they get swollen, it's trying to capture something. It's trying to hold. It caught some sort of infection, some sort of pathogen, and it's trying to trap it right there and kill it if it can before it hits the rest of our body. But that's how a lot of those tonsils work. So these are our swollen tonsils. So if you look at it, my uvula is there, that's swollen. My tonsils are swollen. And then that's the palate, real red and swollen as well. So this is going, if I'm used to having this whole thing to be able to breathe, and now half of it is cut off from the swelling, that's obviously then eventually going to affect my breathing. Okay, now structure of my larynx. Located just below the pharynx, also referred to as the voice box. Several pieces of cartilage form framework. So your thyroid cartilage and your epiglottis. Sorry, your thyroid cartilage is your Adam's apple. And then your epiglottis partially covers the opening into the larynx. You got a mucus lining. Vocal cords stretch across interior of your larynx. Space between the cords is the glottis. So I'm going to go to the picture, y'all. Okay, so the air goes through the nose to the pharynx to the larynx. Okay, you got your hyoid bone. Remember, we talked about that. Your epiglottis. Your epiglottis is here. This is what covers your trach. So this is your vocal cord. Your vocal cords right there, they vibrate. We're pushing air out of our trach when we're talking. So again, I cannot take a breath and talk at the same time because I'm taking a breath, but then I'm using that breath to force a voice out, and I'm losing that breath as I talk. So your epiglottis. Okay, so these are your vocal cords. They vibrate according to the air you're pushing out in order to talk. Your epiglottis here, when I try to swallow food to go down here in my esophagus, this tube, this epiglottis covers my vocal cord. It covers, because this is the start of my trachea where I'm going to take air in. So the epiglottis covers my trachea so that it'll guide food and drink down one pathway. The only way for it to go is down the esophagus. Okay, but when I'm not eating, when I need to take a breath, the epiglottis opens to allow me to take air into my trach. Again, your cricoid college are the C rings to support the trach because it would go limp. Lumen of trachea is kind of the opening. I'm sorry, the round, yeah, close to the opening. And then your thyroid gland sits in front. Okay. Okay, now the functions of it is for air distribution, meaning, again, it is a guide for air just to flow through that tube to get to its destination. Voice production, this includes those vocal cords right there. Laryngeal cancer incidence increases with age and accelerates. Oh, why can't I see my... Oh. Age and alcohol abuse occurs most often in men over age 50. If the larynx is removed, esophageal speech, electronic artificial larynx is needed for speech. So that's that little, if y'all remember, y'all might be too young. But there was a commercial on TV of a lady who smoked, and she would put this little box up to her throat. She had a hole in her throat, and they put her on a commercial. She had an opening in her throat without a trach or anything, just an opening. And then she had a little box she would put up to her throat to be able to talk. If anyone watches South Park, there's a guy on there who also uses a box to put up to his throat to be able to talk and say what he needs to say. But that's what they're talking about. If they have to remove the larynx, remember the larynx contains the vocal cords. It is the vocal cords that produces sound so we can talk. If they have to remove the larynx, then I'm not going to have those vocal cords and I'm not going to be able to produce speech. Okay, so we talked about the upper respiratory tract. That included your nose, your pharynx, and your larynx. Now, when it comes to upper respiratory infections, you need to know the upper respiratory. That's going to be your sinuses. That's going to be your tonsils, or any of those yeah, the tonsils, any of the tonsils. That's going to be the nose, the pharynx, so sore throat. There's going to be strep throat. That's going to be inflammation of your tonsils. That's going to be um again, your sinuses, the common cold, the head, the full head. All of that is upper, has to do with your upper respiratory tract. So, upper respiratory infection is going to include rhinitis. Itis is inflammation. Rhin, R-H-I-N, means nose. So, nasal inflammation, as in a cold, flu, or allergy. Infectious rhinitis is your common cold. Allergic rhinitis is your hay fever. So our body doesn't get fever unless it's trying to fight something. But there is one time that our body will get fever that can actually not be passed on. That is not due to, let me not say that because that's something different too. Okay. Allergies rarely, you cannot pass on allergies like you can flu, COVID, and other upper respiratory infections. But allergies, if the body is fighting real hard to try and get rid of whatever's irritating your body and the air and stuff like that, you'll eventually develop some sort of fever, and that's going to be called hay fever. Pharyngitis is a sore throat, inflammation, or infection of your pharynx. Laryngitis, y'all, this is basically in a word for pharyngitis, itis, inflammation of your pharynx. Laryngitis is going to be inflammation of your larynx, resulting from infection or irritation. So epiglottitis is a life-threatening condition, and this is usually caused by your hep B infection. This is seriously life-threatening because that epiglottis is supposed to be thin enough to be able to cover the trach and open and allow air to come in. So it's supposed to do this. If it starts to inflame, it has no room to move up and down, and eventually the inflammation is going to get thick enough where it's going to automatically cover the trach. No matter if I try to take a breath, it's only going to move this much because it's inflamed and it doesn't have nowhere to move, if that makes sense. So the inflammation is going to end up covering my trach, and I'm not going to be able to take a breath, and I'm going to die without that breathing. So epiglottitis is life-threatening and must be taken care of immediately. It is an emergency. Croup. What I need y'all to know about croup is that it comes with the barking cough. Please, if you see a question on with a barking cough, do not choose epiglottitis. I need you to connect barking cough with croup. If you decide you want to go into peds, if you decide you want to go to cooks, you need to know that croup's main signs and symptom is going to be your barking cough. It is a non-life-threatening type of laryngitis caused by parainfluenza viruses. It produces a barking cough. That is a classic sign of croup. Okay, now disorders of the structure of these things. So deviated septum, we just said when we're doing our head-to-toe assessment, we're feeling for a deviated septum, meaning the middle part, the middle bones that's supposed to be midline and straight is crooked. It is deviated. Epistaxis is bloody nose. What do we do for a bloody nose, y'all? We don't put it back because that blood is going to drain back into our throat, and it could suffocate us or drown us if we take it down our trach. So we lean our head forward and we put pressure. Okay, moving on to the lower. Let me go back here. No. Moving on to the lower respiratory, we got the trachea. The structure of it is like a tube. They have C-shaped rings for cartilage that hold the trachea stable and open. The function is a passageway for air to move from the trach to the lungs. So again, it is just a freeway. It is just a guide. It's a pathway for the air to get to the lungs to get to do gas exchange. Obstruction and blockage of a trachea occludes, meaning it blocks off the airway, and if complete, it will cause death in minutes because it is right in the middle of the trach. We can't get no air in going left or right. Tracheal obstruction causes more than 4,000 deaths. Abdominal thrust maneuver is life-saving. Y'all learned this Y'all will learn this in CPR, but the point of CPR when it comes to the Heimlich maneuver is we're trying to cause a burst of air from the gut, from the stomach and the lungs, to hopefully be forceful enough to dislodge the item to be able to cough it up and clear the airway. Tracheostomy, ostomy, is a surgical procedure in which a tube is inserted into an incision in the trachea so that a person with a blocked airway can breathe. So if someone's nose or pharynx and larynx is not working properly, we have to bypass that to keep them alive. So they'll put a hole, a tracheostomy, they'll put a hole, surgically make a hole, and then they'll put a trach in there, and that trach will now act as our nose. That's where they will breathe in and out through, is that trachea. I'm sorry, that trachea. Trach tube. So structure of my bronchi, bronchioles, and alveoli. Trachea branches. So remember, the trachea is one tube. It branches into your left and right bronchi. And those guide air, but they also contain mucus and cilia as well that assist in hopefully moving things up to the trachea and then moving the stuff from the trachea up so we can suction it or spit it out. Each bronchus branches into smaller and smaller tubes. Bronchioles are at the end. Terminal bronchiole. Let me make sure. Okay, terminal bronchiole, and then we hit the alveoli. That's what this is right here. We hit the alveoli. These are little sacs, oxygen, and if you see all this blue and red, that is the arteries and veins and capillaries, the purplish, are the capillaries. And remember, gas exchange happens at the capillaries. So the air literally diffuses. Y'all see this membrane right here? Our air, that O2 that we take in, actually diffuses. And remember, if it diffuses, that means this needs to be a real thin membrane. Real thin membrane, real thin epithelial tissue, so that the gas can just diffuse easily across it. Because when we take in oxygen, you see how they're blown up. There's a high concentration of oxygen inside those alveoli that want to get out, that wants to get out. And so through those capillaries, it makes that exchange where it drops off O2 and then it says, pay me my CO2. Okay, bronchi, bronchioles, air distribution. Again, alveoli. Your alveoli is to exchange gases between the air and blood. Now, type 2 cells produce surfactant. I need y'all to know surfactant to help reduce surface tension or stickiness. So, if you see how these are round and they're separate, they're not together, right? They're like they're round like this, and they're not together. If you consider a balloon, man, I wish I had a balloon. When you're holding a balloon, right, there's always a little bit of air in there because the balloon is not stuck together completely like this. That's kind of what our lungs do. They're kind of open just a little bit, but it is that surfactant. It is that surfactant that keeps them open a little bit. Without that surfactant, all these, if you put water in a balloon and empty it out, the inside would stick together, and that's what our alveoli would do. If we didn't have that surfactant to help keep it open, to help keep our alveoli open, they would snatch together like two wet papers. And if you've never done it, get two papers, wet them, and then try and pull them apart. It takes some effort. And so if we didn't have that surfactant, our alveoli would collapse like this, and we would not be able to open them to take a breath to then allow gas exchange. They would just be stuck closed like that. This is kind of the same picture, y'all. You can see the alveoli, and you can see all the capillaries surrounding that, so that it will exchange oxygen and CO2. Perfect. You see how, so oxygenated blood comes from the pulmonary arteries to our lungs, right? And you can see where the oxygen attaches to the the arteries attached to the alveoli, and now gas exchange is made. So the oxygen from the arteries, diffuse across that membrane into the alveoli, into the capillaries. The capillaries is where that oxygen nutrients is exchanged. And when it's done, the blood is now bluish because all all that hemoglobin, all that oxygen has been sucked out, and now there's CO2. So now the veins return that blood back through the pulmonary veins into y'all. I just lost my train of thought. But I'm sorry, y'all. But y'all understand what I mean. And right here is where the capillaries will be, where that oxygen exchange happens. Perfect. Y'all see how thin this layer is? That is the alveoli. This is the capillary. So yeah, so you see a high concentration of O2 wants to get out. So it diffuses into the blood onto our little red blood cell, remember? And then the CO2 leaves. The CO2 then exchange into the alveoli, into the lungs, and now we breathe it out through our nose. So we breathe that CO2 out. Just exchange. That's it. O2 goes from the lungs into the red blood cell. The red blood cell drops off the CO2 into the lungs, and the lungs breathe it out. Okay, these are just parts. You got your 3 lobes. You got 2 lobes. You got your heart. You got your diaphragm. Your diaphragm is your most important breathing muscle. If that does not work, you cannot breathe. This, when relaxed, it is pushed up. When you take a breath, it contracts and it pushes down. It pushes down to allow these lungs to expand so we can take a full breath. When we blow out, this then relaxes and pops back up. Okay, this is that transverse view. We've cut her in half, and now we're looking from the top. From the top, you can see kind of how it's structured from the lungs, right? This would be the trachea. The air is going down the trachea, into the bronchi, down the bronchioles, into the alveoli. Okay, now talking about your covers, you've got your visceral pleura. This is actually the inside layer. This touches the organ. When we get to GI, you'll see there's a visceral layer too. Your visceral touches the actual organ. That is the layer of the organ. You got parietal pleura, which is your outside layer. Okay, and anytime you have 2 layers, you're going to have a space in between, and that's usually your cavity, but that's going to be the pleural cavity, which we've talked about. That cavity houses the lungs. And that is, no, was that it? Pleura cavities. Right, y'all? Ventral, thoracic, pleura. Now I'm thinking. Okay, this pleural cavity. So in the mid, there's this space in between those 2 layers. Okay, there's supposed to be a small amount of liquid in there, enough to allow the layers to glide, because when the lungs expand, the visceral pleura layer is going to expand and push towards the parietal layer, and it's going to cause rubbing and friction. So we need a little bit of fluid in there just to allow gliding. Let's go back here. Okay, same thing again. O2 exchange, right across that thin membrane. O2 is dropped off so I take a breath. That O2 then diffuses across my alveoli and goes directly into my capillaries to the blood. And then that blood releases CO2 into my lungs, in which I breathe out. Respiratory distress, relative inability to inflate the alveoli. Infant respiratory distress syndrome, leading cause of death in premature infants, resulting from lack of surfactant production in your alveoli. So the baby usually develops, I want to say, you know what, let me not say that. But when babies are born a little bit early, they go ahead and get a dose of surfactant, because without that surfactant, remember, the alveoli will just stick together and they won't open. And if they won't open, I can't take a full breath in. If I can't take a full breath in, there's no gas exchange happening. And if there's no gas exchange happening, I'm going to die within minutes. Adult respiratory distress syndrome, impairment of surfactant by inhalation of foreign substances or other conditions. Now, we have surfactant in our lungs, but every time someone wants to smoke a cigarette, wants to smoke a blunt, wants to get around dangerous chemicals like bleach or pine saw, or just dangerous things, it's going to start eating away at that surfactant. All right, my lungs, please make sure y'all read that, okay? You got the apex, which is the narrow part, and the base, which is the large part. So your apex is up here. Your base is this part right here. Base and then apex. Okay, you can see how your ribs are around it, protecting your lungs. Same over here. Okay, it's still different over there. All right, structure of my pleura is moist, smooth, slippery membrane that lines chest cavity and covers outer surface. That's kind of what I was going through over there. Again, looking at it from transverse, you can see where the lungs are and how it hits the alveoli is all right here at the edge, okay? And then you got your spaces, right? Your layer that's touching it is your visceral layer. The layer that's not touching it, it's on the outside, is your pleural layer. The space in between these two layers is your pleural cavity. That does have a fluid in there to allow for less friction and allow for smooth rubbing. All right, function of my lungs. Function, breathing or pulmonary ventilation, meaning I am ventilating my lungs. Pleurisy, inflammation of your pleura. So if my pleura were to start inflaming, right, that might put some pressure on my lungs. That might put some pressure on this cavity. Atelectasis is incomplete expansion or collapse of your lung, usually the alveoli. This can be caused by pneumothorax or hemothorax. So first of all, atelectasis is collapse of your lung. And they just changed that definition because it's actually collapse of your alveoli. Which is where gas exchange happens. If my alveoli are collapsed, they're not functioning properly. If they're not functioning properly, gas exchange is not happening properly. If gas exchange is not happening properly, my tissues, my blood is not being oxygenated properly, and then tissues are not being diffused with oxygen properly. Okay, so atelectasis is collapse of my alveoli. This happens by two ways. Pneumothorax. This is presence of air in your pleural space. So, you see you have your visceral layer, which touches the lung, your parietal layer, which is the outside. But then remember this space in between here, right? This space in between the two layers. I didn't realize it got blurry, y'all. But the space in between the two layers, if there's negative air pressure, there's no air in there, okay? It's all a little bit of fluid to allow for movement, but it allows that whole cavity for my whole lung to be in there. Now, pneumothorax means I have allowed air somehow to get into this space, and that's when this happens. Maybe that lung popped, right? And so if there's a hole, first of all, the air in the lung, when I'm breathing it in, it's like a hole in a balloon. You blow, there's a hole in a balloon and you're blowing, but the air is blowing just right out the other end. That's kind of what the lung is. I'm bringing air in, I'm taking breath in, but it's going right out that hole. Now, if I have like I've been stabbed or shot, then I have a hole to the outside of the world, to the air in the world. So the air in the world now rushes in, filling this space that's supposed to look like this, filling the space with air. And every time I take a breath, the air is coming straight out into that space as well. So that is a pneumothorax, when I have air in that pleural cavity where there should be no air. Hemothorax, if you think of HEM, that means blood. So that just means usually blood or fluid in this space, which again, there's supposed to be no fluid because it's going to cause pressure on my lung. It's supposed to look like this. Okay, disorders of your lower respiratory tract. You got acute bronchitis. It says it right there. If you know that the bronchi are in the lower respiratory tract, then you know that the bronchi can get irritated and infected, and that's going to be bronchitis. Pneumonia is fluid in my lungs. It doesn't always have to be infectious or bacterial. Sometimes people who are just drinking or eating and they don't have a strong, they aspirate. It hasn't gotten infected just yet. It is still just fluid in the lungs. Tuberculosis is a bacterial infection, very hard to cure. You have to be in a negative pressure room, meaning it has its own AC vent. You get your own air, and the air that's sucked out goes straight to the outside world instead of sharing rooms with the rest of them. Obstructive pulmonary disorders, I need you to know COPD, chronic bronchitis, emphysema, and asthma. I just need you to know that those are disorders of your lower respiratory tract. Lung cancer as well as part of your lower respiratory tract. Asthma is inflammation of the pathways, right, of your bronchioles and bronchi. A lot of times with asthma, they have trouble breathing out. So if they're not able to breathe out, they're retaining CO2. And at that point, their pH balance is also going to go out of whack, okay? Chronic bronchitis, exactly what it is. Inflammation of the bronchi, and it's been a long time coming. And I want to say that that's usually a result from COPD as well. Okay, mechanics of breathing. So, pulmonary ventilation. Oy. Pulmonary ventilation includes two phases. So in order to ventilate my lungs, I have to inspire air and I have to expire air, meaning I have to inhale air and I have to exhale air. So my inspiration is moving air into my lungs and expiration is moving it out. Changes in size and shape of my thorax causes changes in air pressure within my cavity because the volume changes. Air and fluid is measured in volume. Pressure changes in the opposite direction. Air moves into or out of the lungs because of pressure differences. Air moves from high pressure toward low pressure because when you blow air, it is pressure and it just wants to go anywhere so that it can just chill out instead of being all pressed together with all that pressure. So just like passive transport, higher pressure wants to just be released. Just poke a hole so it can be released. Kind of like the tires on your car. All that air in there is high pressure. If you poke a hole in it, it comes out so fast because it's looking to go from high concentration to low concentration. It just wants to be released. Air moves into or out of the lungs. Okay, we said that. Okay, maybe your module's going to go through it, but I want to go through it here real quick. So when we take a breath, understand that our lungs and our muscles are working all together, right? My diaphragm contracts, meaning it's going to go down to allow my lungs to expand. My internal intercostal muscles are going to lift up, and they're going to lift my chest up. It's going to lift my lungs up. You see, this is going to be pulled down to allow my lungs to expand this way. This is going to be pulled out and up to allow my lungs to expand this way to take a full breath. Okay, when I breathe out, the opposite kind of happens. Whew, okay. So my regulation of breathing, I have sensors, okay? in my medulla oblongata. But remember, respiratory control centers, we also have cardiac centers. But here we have respiratory control centers. Your motor outputs of respiratory muscles. Remember, motor means action. This is sending the signal out to my lungs. My lungs are the effector organ. Here we have an O2 sensor, meaning my body is going to sense low oxygen or high oxygen. CO2 sensor, my body is going to sense whether I have high or low oxygen. My pH sensor is going to say, okay, now we need to balance out this CO2, this acid, and these bases. Okay, but all of these work together to try and control my O2 and CO2. What controls my breathing is my CO2. It is not the lack of oxygen in my body that's going to try and force me to take a breath. It's the buildup of CO2 that sends the sensor to my brain. That is what's going to cause me to breathe. Like if I were to stop breathing, I would retain that CO2. What's going to kick me back into breathing, if it was nothing serious, is going to be that the CO2 is building in my blood. It's not going to be that my O2 is low. Perfect right here. So you see when you blow air in there, the lung blows up, the diaphragm moves down. When we let the air out, it wants to go from high pressure to low pressure, and the diaphragm moves up. Okay, active process. Muscles increase, volume of thorax, decrease in lung pressure, which causes air to move from atmosphere into lungs. Inspiratory muscles, including diaphragm, external intercostals, that's what I just went over. Diaphragm flattens during inspiration, increases top to bottom. Make sure y'all read that. Okay, my volumes. A lot of times you don't need to know these so much unless you're going to work in pulmonology or ENT, but really pulmonology and really with ventilators. Let me not say that. Unless you're going to work in pulmonology, then you really need to know what these mean. If you're going to work with even with ventilators as a nurse, typically we don't really need to know those numbers, because even if we are by ourselves at home health with the ventilated patient, we don't touch those settings. The provider was confident enough to set those settings on that ventilator and be sure that that patient is going to survive or be okay with those settings. So we do not touch those. The respiratory therapist does, or the RN, or we make a phone call to the doctor and the doctor gives us the verbal order and signs the order within 24 hours or something like that. So we really don't, what we need to know on ventilators is high pressure, low pressure, but you do need to know this for this, okay? Volumes of air. So remember, air is measured in volume. Is exchange and breathing be measured with the spirometer. Y'all just saw the spirometer today. Tidal volume is the amount normally breathed in and out with each breath. So if you're sitting there just listening to this video, the regular breathing that you're doing now that you weren't even paying attention to, that's your tidal volume. That is the amount of air that you actually take in and the amount of air that you breathe out when you're just at a resting period. Your vital capacity is the largest amount that one can breathe out in one expiration. That means how much can I actually put out if I were to pay attention and I'm breathing out. Okay, expiratory reserve volume is the amount of air that can be forcibly exhaled after expiring tidal volume. So when I'm just breathing there regular right now, if you're just listening to this video and you're just breathing regular, right? You weren't even paying attention to it. I'm sure you are now, but you weren't even paying attention to it. Once you breathed out, how much more can you breathe out? Can you force out? That's going to be your expiratory reserve volume. And tells you right here, your inspiratory reserve volume should be about 3,000 to 3,300. Respiratory reserve volume diminishes. We'll kind of tell you how it goes. Tidal volume is usually about 500. Your expiratory is usually about 1,000 to 1,200, and so on. All right, regulation of ventilation permits the body to adjust to varying demands for oxygen supply and carbon dioxide removal. So your brainstem, your central regulatory centers are called respiratory control centers. They are located in your let me not say that. Medullary centers. Under resting conditions, the medullary, y'all know what I mean, rhythmicity area produces a normal rate and depth of respirations. Depth. Central regulatory system pontine centers. As conditions in the body vary, these centers in the pons can alter the activity of the medullary rhythmicity area, thus adjusting breathing rhythm. Remember, your rhythm is regular or irregular. Is it regular? Is it short of breath? Is it tachypnea? So that's your rhythm. Brainstem centers are influenced by information from other parts of the brain and from sensory receptors located in other body areas. Okay, so to regulate your breathing, cerebral cortex is voluntary but limited control of respiratory activity. So your receptors influencing respiration are chemoreceptors. They respond to changes in your carbon dioxide, oxygen, and blood acid level located in your carotid and aortic bodies. So when that blood pumps out the aorta from the left ventricle to the aorta to the body, it also supplies the top of the head, the neck and the head. So, but you have these receptors sitting in your neck that it can feel, hey, that pressure is a little too high. You put that pressure is too low, that pressure is too high. And it's going to send the signal where it needs to go. Pulmonary stretch receptors respond to the stretch in lungs and thus protecting respiratory organs from overinflation. Okay, know these. Eupnea is normal breathing, hyperventilation, rapid and deep, hypoventilation, slow and shallow. Dyspnea means difficult. Orthopnea means this is difficulty breathing, but it stops when I move into upright or sitting position. There's also apnea, meaning stop respiration. That means these people who have apnea, sleep apnea, they usually stop breathing for about 20 seconds or more, and that's when they'll diagnose you. Chain stoke respirations are a cycle of alternating apnea, hyperventilation associated with. So this is more like just a change in different breathings. You can't get a regular rhythm. It's kind of all over the place. Respiratory arrest means I'm about to die. Failure to resume breathing after a period of apnea. Meaning I've had apnea for about 20 seconds and I'm still not picking up a breath. I'm in respiratory arrest. All right, pulmonary gas exchange. Carbaminohemoglobin, remember that means CO2, breaks down into carbon dioxide and hemoglobin. Carbon dioxide moves out of lung capillaries. Make sure y'all read that. Oxygen moves from alveoli into lung capillaries. Hemoglobin combines with oxygen, producing oxyhemoglobin. Make sure y'all read this. Oxyhemoglobin breaks down into oxygen and hemoglobin. Make sure y'all read that. Transportation. Transport of oxygen. Only small amounts of oxygen can be dissolved in the blood. Most oxygen combines with hemoglobin to form oxyhemoglobin to be carried into the blood. In the blood. Because remember, the blood transports nutrients, CO2 and O2. So my transport of carbon dioxide. Dissolved carbon dioxide, carbaminohemoglobin, and bicarb. So that's how we... Nope, let me not say it. Kind of want to go through this, y'all. Okay. Tomorrow at some point I'm going to work on that questionnaire. I'll send that out, but I need you to watch this video. I need you to also remember that we need to set up a Teams, okay? I need to really try and set up a Teams. We can do a little bit of tutoring online tomorrow towards the evening, okay? And whoever can make it, great. If not, no worries, because on Thursday we'll go through our questionnaire like we did last time, okay? I was going to hit the endocrine, but it's kind of late. So we'll kind of I'll put that on the questionnaire, and then we'll talk about it on Thursday as well.